Ladies and gentlemen, colleagues and friends, I welcome you, and it's my honor to be here in this building for knowledge and to be part of second Precision Medicine Networking Forum. I will co-chair this session together with ZANNA KOVALOVA. She is an experienced hemato-oncologist from Children's Clinical University Hospital, and I represent Children's Clinical University Hospital as well. I believe, and actually we know, that this session is the most important session in this forum, because we will talk about precision medicine for oncological pediatric patients. It means that we will work for our future. And thank you everybody, experts, stakeholders, supporting this idea to support pediatric oncology in Latvia. We have excellent list of speakers in our session. There will be representatives from Lithuania, Latvia, Germany, and Netherlands. And we are honored to ask our first speaker on stage.
It's my honor to invite Jelena Rascon, Head of Pediatric Oncology Hematology in Vilnius University Hospital, who will tell us about clinical trials in pediatric hematology oncology. Please, Lena, floor is yours.
So thank you very much, dear colleagues, dear organizers. It's a pleasure to be here. Thank you very much for inviting me. And my background, I'm a pediatric oncologist. I'm heading the Center for Pediatric Oncology and Hematology at Vilnius University Hospital Santaros Klinikos, and I will try to give you an overview on our twinning experience within the Horizon project and how it helped us to implement clinical trials and why it is important. So I have nothing to disclose, and for those of you who are not pediatric oncologists, I would like just to remind you that childhood cancer is a very rare disease. As you can appreciate from this graph, the incidence that the childhood cancer comprises less than 0.5% of all cancer cases. These are our Lithuanian data, but this frequency is worldwide. And childhood cancer differs from adult cancers. As you can see, our main pathology is acute leukemias, followed by CNS tumors, and this is a range of heterogeneous solid tumors. And nowadays, childhood cancer became curable for most of our patients, but we can see that this progress was achieved through over many decades, through the academic collaborative activities within non-industry-driven clinical trials. And the latest population-based Eurocare study reports that nowadays the survival of childhood cancer reaches 81%. However, in the latest decade, the improvement was very little. However, the inequalities across European countries still persist and ranges from 71 to 87%. And actually, the lowest survival rates come from widening, so-called widening countries, where the research indicators are below European average. So what matters for childhood cancer survival? This is, of course, tumor-related factors as biology, stage, patient-related aspects as age at diagnosis, genetic predisposition, and of course country and or center-related resources as human resources, infrastructure, patient volume, and experience in nursing skills, and of course participation in clinical trials that now became a standard of care. And as you can see from this graph, the survival rates are much lower in countries with limited resources to support this infrastructure in terms of clinical care and research. If we look at Lithuania, so Lithuania is also a small country, so we have a lot of challenges being pediatric oncologists like Latvian colleagues. I would say it's much, well, I would dare to say that it's easier to be a pediatric oncologist in a bigger country. In Lithuania, as you see, our population, we have less than 3 million and less than 500,000 children. We have 2 pediatric oncology centers, and our center in Vilnius, we concentrate leukemia and hematopoietic stem cell transplantation for all the countries. Over decades, we achieved some progress in survival rates by our own experience, investing in our learning education, improving our infrastructure. However, we were deprived from participation in clinical trials, and our first strategic partner was NOFO countries. With them, we begin twinning since very early years 2000, and gradually this collaboration became closer, and we became, Lithuania became the first Baltic country who joined the NOFO society, and now we are happy to say that all 3 Baltic countries are within. And this collaboration translated actually to our joint clinical trial, the first one on ELL, and actually you can see on this graph that within 5 years the fact to be a member of the collaborative research, it helped us to improve event-free survival of 11% within 5 years. That's really quite good results, and of course it helped us to improve our research profiling in terms of publications. And now we are participating in the next trial that also this is only our Lithuanian cohort that did not improve very much in terms of event-free survival, but overall survival is up to now is better than in the previous trial. So what about solid tumors? So the previous EuroCare 5 analysis showed that Lithuania had one of the lowest survival rates for children who were treated from 2000 to 2007. And actually, we assumed that this was due to insufficient networking with research-intensive countries where that drive Europe, that lead research in solid tumors. So to overcome this networking gap, we responded to the Horizon 2020 call for twinning and built a consortium for the project that is called TREL, Twinning in Research and Education to Improve Survival in Childhood Solid Tumors in Lithuania. And actually the scope is target, first of all, so-called widening countries. As you can see, they are depicted here in green. And as I've mentioned, they underperform in research and innovation. So the scope of the call was to strengthen research profile, first of all, of an institution from a widening country to enhance scientific and technology capacity and to improve the capability to compete successfully for research funding. So we focused on solid tumors and built a consortium. Those of you who are involved in pediatric oncology, so this is the list of the most prominent research, leading research institutions who are leading research in this area, and we focused on the most frequent tumors like CNS tumors, neuroblastoma, and renal tumors. So this is the concept of the project, but I will not go through it. It's quite complicated. The main goal of the project was to increase the research excellence of our institution and to enhance its reputation, attractiveness, and networking channel in the field of pediatric solid tumors. And to achieve this goal, we split it in several objectives. We aim to increase knowledge sharing in basic and translational research, to gain specific knowledge and skills to handle innovative therapies in early phase clinical trials, what matters for today, to foster research and collaborative activities in clinical research, and to increase our preparedness for prospective clinical trials. Also, we wanted to scale up research on survivorship and late effect and strengthen capacities of our institution in research management and coordination of large-scale projects. And publications also was within this scope. So twinning methodology was, we had several educational meetings related to each task. A lot of our staff, more than 40 professionals, this project provided us support to second them to the partner premises to get new knowledge. We had common virtual boards, and our professionals, they participated in knowledge transfer meeting. Also, we initiated some research in biology. And one of the tasks we had to fulfill to initiate clinical trials on CNS and renal tumors and to implement late effect research. So as per the project definition, we had to sign within these 3 years an agreement to initiate a clinical trial on CNS tumors and to initiate umbrella study led by Prinses Máxima Center, and also we were expected to join European clinical trial working groups. So this is the list, just for you to have an overview, the list of meetings where we participated, but probably the most important, this is the list of colleagues who join this research working groups, because we know that the science actually is born within this working group, and then it comes to publications and is disseminated. So these are the agreements signed as we were expected to do. But what also important, being a coordinator, being a part of this project, it increased our visibility, and we were approached to become a partner of these other 4 clinical trials and observational studies, and where we succeeded to start working on them. And all this work, it translated in increased number of ongoing collaborative research. As you can see from this is the number of ongoing studies, and 14 is in preparation now, but this also implies a huge paper burden that is familiar to probably most of us. So we definitely need a dedicated research infrastructure as a clinical trial coordinator, especially for academic setting, because we know if we have a industry-initiated clinical trial, they provide also support to deal with all the documentation and legal requirements. We still face limited possibilities to have a protected time for research. The local, let's say, local funding is not adequate for the volume of research provided, and we must say that we have this equal or the same paperwork for a small number of patients we can recruit for a potential study or clinical trial as centers or countries with a huge, with a much bigger population and volume and potential study participants. So this is also a time-consuming process. It takes normally from 1 to 3 years. The first step is clinical, an agreement signing process that actually is quite laborious process, and as you can see, all this paper documentation related process, it takes its time. We have, I must say that we have some certain institutional support, as our pediatric oncology center is a part of Vilnius University Hospital. That's actually a huge tertiary care university hospital. So we have an institutional biomedical research department who, let's say, monitor us and provide some support. We have a specialized lawyer on clinical trial agreements, because we know that there are differences in GDPR interpretation and also in biomedical research legislation across countries. And at our center we have a clinical trial coordinator and research nurse. I must say that some issues and some delays, they come from sponsor-related issues. So this is the last high-risk neuroblastoma clinical trial that Gustave Roussy is the sponsor, and you see this is a long way. They have to negotiate, submit documentation, wait for response, and so on. So now Lithuania, we are blocked somewhere here, like several other countries. So we are waiting for the permission of the sponsor when they will solve some bureaucracy-related issues. So nevertheless, the work is hard, but I think we are committed as pediatric oncologists to provide equal access of the information related to the clinical trials. And I think this project, it opened us, a small country, opened us the door or access to the most recent innovation in pediatric solid tumors. So with this, I would like to conclude that we hope that survival differences or inequalities across widening European countries, although they still persist, they will diminish, they will decrease, and disparities in research translate into inequalities in treatment outcomes. And this Horizon 2020 Twinning program, it's a very good platform actually for our countries to have a research breakthrough, although it really costs to submit an application, and it was really a learning process for us also. And as the next step, adequate research infrastructure is crucial to support these research activities that are initiated and that need to be supported. So thank you very much for your attention.
Thank you, Lena. My sincere congratulations to your hard work with implementation of these clinical trials. We are on the way. Thank you.
Thank you very much. We share a lot both our countries. And now from Lithuania experience, we are moving forward, and I'm happy to invite Bastiaan, Head of Laboratory for Childhood Cancer Pathology from Prinses Máxima Centrum in the Netherlands. And he will share the ultrafast molecular profiling of pediatric brain tumors during surgery.
Okay, good afternoon, and thanks for the invitation. For me, it has already been a very fruitful meeting, I would say. We had fruitful discussions yesterday and during lunch. And let's see if I can add something to the meeting as well. So today I wanted to talk about methylation profiling, so tumor classification in brain tumors. And as I was introduced, I'm responsible for diagnostics in the Prinses Máxima Center. And we can all agree, I think, that as a diagnostic lab, we have only one thing to do, is that provide the physicians with a proper diagnosis. Luckily, hopefully also with some prognosis information or some targeted treatments. But all of this is very useless if we don't do it in a clinical relevant time frame. I mean, if we take 3 months to provide an NGS result, then I don't think the clinician would be very happy. And this brings me to the brain tumors. So this is what we do normally in a normal standard of care diagnostic setting. And I wanted to talk to you about methylation profiling. So just one slide. I assume that everybody knows what methylation is, but it's an epigenetic mark which is added or removed during differentiation of cells. So on the picture here, cells terminally differentiate into a mature cell, and then specific genes are activated, which sometimes mean that methylation marks are lost, and some genes are silenced, and these could be methylated. And if some of these cells turn into cancer cells because of mutations, then these methylation marks are often maintained, so they're very stable marks. And that means, if you look, so here at the bottom, that these marks are very cancer-specific for the cell types they originated from. And that means we could use them in diagnosing the tumor. And that's what the group in the DKFC did in Heidelberg under the supervision of Stefan Fister. This is a hallmark paper from 2018 where they classified almost 80 different types of brain tumors. And as you can see in the TSNE plot, you have all these different subtypes that can be classified purely on the methylation profile. And not all of this of these classes are clinically relevant, but some of these are. And that has been widely accepted, and I think brain tumors are the best example in pediatric oncology where really the molecular profiling is really helpful in diagnosing these tumors, so much more even than the histology alone. So this is basically how it's done nowadays. We use an EPIC array from ELINA, which is very robust. Everybody uses it. It works on FFPE. It's great. There are two drawbacks, in my opinion, and that's it's quite expensive. You have to have some capital investment to get the machines going. And it's inconvenient that you need 8 patients on a chip. If you have 1 patient, it gets really expensive. If you have 9 patients, you're also in kind of a dilemma what to do. And next to that is that it takes several days. So partly because of this batching, some labs, start to collecting patients until they have 8 patients and then do the test. But even if you would do it immediately, it would still take a few days to get the results. And that brings me to the timely diagnosis, because the main treatment option for pediatric brain tumors is still surgery. And as a surgeon, you want to be perfect. You don't want to do too much and harm the patient by damaging the normal tissue, and you don't want to do too little and leave tumor remnants in the brain and have to do a second surgery afterwards. And the thing is that it really depends on the tumor type you have. So if you have, for example, diffuse midline glioma, which is a really dismal prognosis for these patients, they will die. You'll probably want to leave something and preserve the quality of life. We know that for medulloblastoma, you can leave something and the chemotherapy and the radiotherapy will tackle that. While for ependymoma and ATRT, for example, you want to be as radical as you can to maximize the survival chances for the patients. Well, as said, you want to have a diagnosis during surgery, which is what we try to do. We get tissue within the lab. The surgeons ask for a fresh frozen section, so the pathologist looks through the microscope. But he or she can then tell only so much. So it's not a really detailed diagnosis. And then afterwards, we have the microarray, the immunohistochemistry, and then we tell them what the final diagnosis was, which sometimes results in a second surgery or the notion that you could have done less. What we really try to do is see if we could retrain this model and do the methylation during the surgery. And for that, we cannot look at the EPIC arrays because that whole procedure simply takes too long. And we looked at nanopore sequencing. And for the people in the room which are not familiar with nanopore sequencing, this is truly different than the ELINA types of sequencing that most of us use. It is a pore which sits in a membrane. It pulls a single-stranded DNA molecule through the pore, and while it pulls the DNA through the pore, the currency over the membrane changes depending on the DNA molecule that's in the pore, so the composition of the DNA molecule. And you see a kind of a plot on the right that the currency changes, and there's an algorithm which can tell you what the DNA composition was. And not only the A, T, C, and G, but it can also sense if there's a methylation group on the DNA. So it's really, really fast. Once one DNA molecule sequenced in the pore, which takes seconds, you get the data and you can analyze it, which is truly different than the ELINA machines, for which you have to wait till the end of the run. Sequence data, methylation data, and it's pretty cheap. You can reuse chips, you can pool samples, so it's not if you have only one patient that you're done with the chip. You could wash it and reuse it again. So we tried to look at this, would it be something we could use? And we have one problem. There's a really good classifier around from the DKFC, which is based on the ELINA arrays, which you see a typical picture on the left, with in red and blue the methylated and unmethylated sites. But if we now start nanopore sequencing, we basically perform shallow whole genome sequencing, and we hit CpG sites in the genome at random. If we sequence the patient again or another patient, we would probably sequence different CpG sites. So this is mimicked what this would look if we mapped the CpG sites we sequenced for 5 minutes or after 45 minutes, how that would look on an array, and you see that we would only hit at maximum 1 to 8% of the sites that are on a methylation array, which is not good enough to use the classifier that's built by Heidelberg. So it's random data and very sparse. So there are 3 ways to solve this, basically. You could sequence the whole genome, and then you have all the sites, and you could classify it, but that's still expensive and would take too long, so that doesn't work for us. This is a trick that has been used by the people mentioned below, and which also triggered us to look at this. What you could do is start sequencing, stop the sequencing after 1 hour, see what CpG sites you analyzed, and then retrain the original classifier from Heidelberg purely using those sites. For that you need the original data, and the real problem for me in diagnostics is that it's a real patient-specific classifier. You cannot validate it. It's only valid for that patient, for those sites you sequenced, but there's no way of knowing how well it performs. So we really looked at the third option, is to get a classifier upfront, which is really fast if we want to use it during surgery, and which we could easily share with others. So what we did, we looked at the original data set from Heidelberg with almost 3,000 patients in there, the samples, and we binarized the data to nanopore data, but not just as just a simple binarization, but what we did is mimic if it were generated by nanopore sequencing. So we really looked at what would this data have looked like if you sequenced it for 5, 10, 15 minutes, how long would the reads have been, and what would you then have sequenced. And this is a picture of what it could look like, and since we only then get really small data set of this array data, we could do this not once, but a few 100,000 times per sample, which means we really upsampled this and trained the algorithm by doing this 40 million times for half of the data set and then rotated this model. So this is really a neural network training approach. So it's like for us now also a black box. We're not really sure how the algorithm works. What matters to us is if it works. So with that, obviously, we validated it. On the x-axis is the sturgeon, what we called the algorithm in nanopores. All the algorithms are based on fish names somehow. And on the y-axis is the DKZ version 11.4, and you see that the performance is really good. Even during surgery, you probably don't know the really detailed diagnosis. We're probably okay with the large group of family where the tumor falls in, and you can see that we almost reach a perfect score. And this is a typical picture. So we analyzed retrospective samples for which we did epic array data and mimicked how that would look. I'm not going to show you the data. Obviously, we wanted to know how well it works if you really start nanopore sequencing. So we took samples out of the biobank, and I'm going to show you some pictures. On the x-axis, you see the time or how long we sequence, and on the y-axis, you see the score for the different tumor types. There are actually 80 different lines, but the ones that have a score of 0 are not depicted in this picture to make it more clear. So you see in this case that after 5 minutes, you already can see that it's classified as an ATRT with a MIC amplification, but not with a perfect score. After 15 to 20 minutes, we reach a perfect score, and we did this for several samples in the biobank with different tumor types, and we see that it works really well. All samples, we had a classification within 40 minutes, but on average, our diagnosis time was after 18 minutes of sequencing, which I find still amazingly fast. And then we started moving it during surgery, so do it per-operatively, use it next to the surgeon. You can see the case over here. We also included some adults to increase our cohort. For the 25 cases we initially did, 18 were concordant with the EPIC array which we ran after that. 4 did not result in a reliable classification because of low tumor purity. We think we've tackled that now in the procedure. We usually now make a library prep of two or three small pieces of tissue, and then the pathologist tells us based on the frozen section which is the most representative. That's the one that we start sequencing then. And 3 were really exotic cases, meaning they were not part of, they couldn't be classified because the class is not in our classifier, and could also not be classified based on the EPIC data, so the EPIC classifier. Paper came out yesterday, so look at it, and there's, I think, a download link for the script, so you can use it yourself. So what we really wanted to do now is see if we can upgrade this classifier to the latest version of the Heidelberg classifier, which is version 12.5. For that, we obviously need the data, so we're discussing that. We're solving practical issues. We use now one chip. We might want to use two chips. It's even faster, and it's like a fail-safe. If one of the chip fails, then you have a second one. And since you can reuse them, that's not of a big issue. And we're really considering now, as for the pediatric, but also for adults, to validate this in a prospective ongoing study to see how well it performs in daily practice on multiple sites. And since this algorithm works, so the algorithm is trained on site, so you don't really have to send the data to a central place. We could send the algorithm to a site, you could train it on site, also solves the privacy issues with sending some of the data. So we're really interested to see if we could collaborate with people on this federated learning approach. And obviously, and we had some discussions already yesterday, you could have similar applications for other tumor types. Obviously, I don't think it would always be necessary to do that during surgery, but it opens the possibility to have a really fast diagnosis. And these are the people involved, the group of Jelena, which did a lot of the AI work, and then the surgeons and pathologists in the Amsterdam UMC and the Prinses Máxima Center. Thanks for your attention.
Thank you, Bastiaan, to tell us about this fascinating possibility. I definitely know your question will follow. But now we are inviting a next speaker, Dace Enkure from Children's University Hospital. It's a molecular genetic. And Dace will tell us about our local molecular tumor board.
So hello. So I'm Dace Enkure. I'm from Children's Clinical University Hospital. I will tell you about the development of tumor board in Children's Clinical University Hospital, more in the terms of molecular tumor board. So let's start. What is the tumor board? So historically, tumor boards were general tumor boards attended by medical oncologists, surgeons, radiation therapists, so on and so on. So clinical doctors sat together, speak about the process, what to do with the patient, what can be the consequences, and so on. Recently, as many other things are developing, and then also pathology and molecular genetics, then most of these centers now have also these specific tumor boards, molecular tumor boards or organ-specific tumor boards. And of course, institutions and doctors rely on these tumor boards to make sure that the quality care and state-of-art patient management is implemented. So in Latvia, we have approximately 50 cases per year of pediatric oncology. Not most, but actually all cases come to Children's University Hospital. And this count is plus minus the same, but sometimes you can feel that sometimes you can get more samples, and it means that these cases are growing. And of course, in pediatric oncology, each case is unique and very specific to the patient, and not only in the terms of the patient, but also of the tumor itself. About the localizations, of course, in pediatric cancer cases, you already saw in the first presentation that they are quite specific in terms of localizations, and there are quite a lot of them. So what about the Children's Clinical University Hospital? Actually, tumor boards in Children's Clinical University Hospital, in its broadest sense, involving all the clinical doctors and specialists, are part of patient care gold standard already for a long time. In each case, when specific opinion is needed, then the patient is discussed together to obtain the very best solution and treatment for each patient individually. In most cases, of course, the patient is discussed before the operation and therapy is started in order to choose the best treatment. And of course, sometimes when it's needed, it's also about choosing the best therapy, how to management difficult cases, what to do about the radiotherapy, and so on and so on. So since the end of 2021, molecular biologists also have joined tumor boards. And since this year, also medical geneticists have joined tumor boards. So how it all started. So molecular testing of pediatric cancer patients at Children's Clinical University Hospital started at the beginning of 2022. Actually, we started this all already at 2021, but we were ready to start it last year. We made algorithms for each case, for each patient, for each tumor localization. And of course, it included as much as possible of all methods that are available. So it means that whole exome sequencing of normal tissue, deep whole exome sequencing of tumor sample, and also the RNA sequencing of tumor sample. So how it looks for the patient. So for example, if we have the patient with hematological malignancy, then we sequence, in most cases, it's the DNA from hair, follicles, or skin biopsy in cases when it's hard to get the DNA from the hair. And then, of course, tumor tissue. Most cases, it's preserved or fresh tissue, so it means we can get a better quality of the DNA. And of course, different tests are done, and everything is done as soon as possible. Of course, in some cases, we use also paraffin-embedded tissues, and of course, then we put this all information together and give it to doctors, and then they can decide what to do next with the patient. For example, with solid tumor tissue, so kidney tumor as example, so one thing is this methylation specific MLPA, which is needed for diagnosis, testing of entire CAR fusions, most common translocations using the real-time PCR, of course data analyzing, interpretation of deep whole exome sequencing, and also deep whole transcriptome sequencing. Validation allowed us to use data of deep whole exome sequencing and replace Wilms tumor specific MLPA, which is very important in Wilms tumor. And also we can now use the exome sequencing data instead of TMA analysis for solid tumors. So what is done? So for molecular testing of cancer patients, for germline testing, we have in total right now, maybe it's already a little bit more, 74 pediatric malignancies patients was performed. So we had 30 patients with hematologic malignancies, and it's 44 patients with different solid tumors. So as you can see, with the hematologic malignancies, we had 4 positive cases, and with solid tumors, 8 positive cases with the germline testing. So molecular testing of cancer patients about the whole transcriptome sequencing. Regarding different types of these tumors. So of course, for hematologic cancers, these translocations are most important. Also for CNS tumors, and of course, sometimes we see also in other solid tumors translocations. Deep whole exome sequencing. So here I need to go back to the sentence that in pediatric oncology, each case is unique and specific to the patient. So it means when we analyze this deep exome sequencing, then we can see that these mutations differ from patient to patient, from cancer to cancer. And each result is very specific to individual tumor, and we need to pick out this information which is needed for doctors to make sure that diagnosis is correct, that maybe there are some targets which could lead to better therapy, and of course achieve the best treatment for each child. So about the molecular tumor board. So it started actually as the meeting of molecular geneticists and hemato-oncologists for a while ago, and just to discuss the results of these molecular genetic testings, because we all know that doctors sometimes don't know genetics so well, and then there are we geneticists who tell the doctor that, hey, this mutation is very important, maybe you can try this therapy, and maybe it could work. Of course, the main is doctor, and he or she decides what to give to the patient and what to do with the patient. But then we can just share this knowledge, what we have, with the doctors, and doctors also then gain more of the knowledge of genetics of the tumors. We also have medical geneticists joined to discuss patients with probable hereditary syndromes as well. And yeah, we had actually one case when we get the results and we see that there is hereditary syndrome, and the children actually was not diagnosed yet, so we need to turn also to the medical geneticists, and then the medical geneticists also join these tumor boards. So how it actually looks in molecular tumor board. So it means that we put together all the tests, what we have done, what our colleagues have done, and then we can see that what we have found, what we can do with that, and then we can just discuss all these results. In this case, it was IML case. In karyotype and fish analysis, we had translocation of chromosome 3 with unidentified chromosome, and actually with transcriptome sequencing, we were able to say what this translocation is. Also, in these cases, was done at SMA. Also, the results you can see then, and of course, for hereditary mutations, there was nothing found, and deep whole exome sequencing at the first time, it was different mutations, but yeah, I will have the next slide also. And the next time we had some mutations which we found at the beginning, and also at the next time. Together, the patient was sequenced 3 times. It was a very interesting case with some clonal changes different. At the first testing, she had FLT3 internal tandem duplication, and which at the second time was already gone. But then we had NF1 somatic change, which we can see that at the first time it was 42%, then it was 74%, and at the beginning it was already 96%. So yeah, unfortunately she did not survive. But yeah, so next, so it's also one of the examples about the identifying novel fusion partners. So in this case, as I said, in fish analysis, the finding was that there is something wrong with the chromosome 3, and they don't know what is the partner of the MECOM gene. So, and of course, in literature and databases, there have been described few cases with MECOM translocation with some unknown gene with increased MECOM expression. And using the transcriptome sequencing, we could see that the gene, which even doesn't have his own name, is making this translocation with the MECOM. So in solid tumors, this case was actually pretty good because the patient could get the clear diagnosis and the better treatment. And the child was diagnosed with hepatoblastoma with cholangioblastoma subtype. But during the analysis, we found the translocation, ATP1B1 with the NRG1, which changed the diagnosis of cholangiocarcinoma. So, of course, it's plus minus the same location, but still this type of the tumor is a little bit different. And of course, for this type of diagnosis, there is available targeted therapy with afatinib. And next one, so this is germline testing. So we had ILL, second relapse already. Age at diagnosis 7 years. Nobody didn't suspect any hereditary changes. But during the testing, we found that the patient is carrier of PTPN11 change, and it made the diagnosis of Noonan syndrome. And actually, the Noonan syndrome is one of the syndromes where the children have quite high risk of developing not only leukemia but other cancers as well. So, and this was the case after which we also were talking to the medical geneticists, and medical geneticists were involved in this tumor boards as well. So what would be the development and future directions? So of course we need to continue these molecular tumor board meetings. Most probably, maybe we can integrate these molecular tumor board discussions in specific cases also in the large tumor board together with all the clinicians. And of course, the main thing is to find a solution for each of the child and provide quality care and state-of-the-art patient management. Thank you for your attention.
Thank you, Dace, for emphasizing our communication. It's really very important during our work. Thank you, Dace.
Communication is the main thing.
Yeah.
Thank you, Dace. We already heard 3 lectures, 3 different presentations, and we will have a question and answer session at the end. And therefore, I ask you to write down your questions and to try to remember what was in your mind when you listened to the first 3 presentations from Lithuania regarding clinical trials and role of research, about the second presentation about how to do things faster to help our clinical colleagues, and about molecular tumor board in Children's Clinical University Hospital. And now I'm very happy to invite a colleague from Mirjam Blattner-Johnson to tell us about INFORM and the 10-year experience from.
Thank you for the introduction, and I'm very honored to be able to share with you what we have learned for the past 10 years. So first, Professor Pfister asked me to send you his warmest regards. He wasn't able to come and present himself, but and he also said we are currently building a new facility for us where we also have, similar to the Prinses Máxima Center, where we have the patient care and the research in one building. Should be up and running 2025, and he asked you, whoever wants, please come visit us. So back to INFORM. Where is actually the medical need for programs such INFORM? And as we already heard before, for the past 40 years, we actually did quite a good job, and 80% of cancer of kids diagnosed with a cancer are actually getting cured. But these 20%, the last 20%, are really like suffering, and we need to define this 20% better, so maybe even be able to start already with a better targeted approach. And a point I want to make, and I guess the audience here is well aware of it, just looking at the different entities between pediatric and adult cases, you can clearly see right away kids are not small adults, and we need more precise treatment for kids and not just apply what we have for the adults and treat the kids with it. Just a couple of the challenges we're facing, especially in pediatric entities. There are hundreds of molecular distinct tumor types, but all the diagnostic approaches are usually just per entity and not per subtype. And the treatment approaches we're currently using does not match by far the molecular complexity we're facing. Another challenge I just mentioned, those 20%, once the pediatric patients relapse, the overall survival is very, very poor, and they're usually dying within weeks to months. Now, switching to the opportunities, we all know with the recent development of genomics or the sequencing technologies, the time it takes to sequence a genome went from, at the beginning, from 10 years now down to sometimes only a day. And the same is with the cost. Yeah, it went from 300 million to sequence the human genome down to 1,000 euros. So this really enables us to sequence many more patients. Opportunity sometimes is a challenge. The kids have a relatively simple genome or tumor genome. So if you can see here on the right, this is an average mutational burden for adult cases, and versus here, it's tenfold less in the pediatric cases, which makes the tumor simple. So quite often we only have one key alteration we can target, and sometimes also tricky because quite often we can't identify a key alteration at all. With the recent high amount of research going on between targeted or specific targeted treatment, you can see down here, over 1,000 new oncologic drugs are in development, but unfortunately only less than 10 were filed specifically for kids in the past 50 years. So we really have to push to get more pediatric clinical trials and also drug development going. And this is also where Inform hits. So we started a little bit over 10 years actually ago, and at the beginning it was a German-wide precision medicine program. You can see now currently 13 countries sending material to us, and we have over 100 centers, so it's also sometimes quite challenging to coordinate everything. And this is the workflow for Inform. So our goal is to deliver data within most 21 days. What we do, we are doing low coverage whole genome sequencing, exome sequencing. We're currently switching to high coverage whole genome sequencing, just because it's almost the same cost. And we're expecting much more precise data, especially for little things like IDTs, very small partial deletions. So that's definitely going to amplify or precise our results. Then we run RNA-seq, mainly for the fusions and the transcriptome. And just because we're Heidelberg, we're also doing methylation for all the cases, not just the brain tumor cases. But obviously the biggest benefit here is for the brains and the sarcomas. This is where my work starts. So usually by Tuesday, we get the results, which are prepared already by our bioinformatician. And then by Friday, we have the tumor boards. So it gives us about 3 to 4 days to prepare, to filter out which one we think is relevant for the patient, to prepare the tumor board, to invite the treating physicians and prepare all the documentation for it. When I started with Inform, which is now also like 7 years ago, I think, we usually had about 4 cases per week. Currently, we're running between 10 and 15 cases per week. So you can see, this was, I think, I updated it in May this year. So back then we had about 2,800 sequenced cases, which is down to 2,500 patients. We're getting more and more relapses now as it's going on. Probably now we're closer to 3,000 patients. It's all fresh frozen material, mainly high-risk relapse cases, but also, for example, for high-grade glioma, we are doing right-away primary, or if a child presents already with a lot of metastasis at the beginning, so where we know, okay, it's a super high-risk patient, and we also sequence primary. One thing we're pretty strict about is the time of sample taking. So this material can't be older than 8 weeks. And you can see that our percentage of really sequenced material is pretty high, so it gets better and better. So we're not losing too many samples just to QC. And from the representation, it's kind of as expected. So a huge part is sarcoma and brain. Not so much liquid tumors, because there are also a lot of programs already successfully running. A big challenge we had at the beginning was how we translating our gut feeling, what we think which targets are important to actually a real score. And this is still ongoing to define this, but I think the biggest differentiation what we do is in this step whether it is a genetic event or just based on transcriptional event. And then you can see, depending on how it is, if it's genetic, is it a known alteration, or is it are there already papers published out there that they have already successfully treatments? And then we end up with different scoring from very high to very low. And you can see for the very low, obviously, for almost all of the cases, we find a target. Unfortunately, a target from very high to high priority, we found in about 22%, in 1/4 of our patients. And you can, and for the very high target, I think we all know, the most frequent high target are the NTRK fusions, and it's roughly about 3% of the high-grade glioma and the sarcomas. And there's a really good response rate with LOXO-101, as you can see here as well. I think it was actually a patient from Sweden, and the tumor melts really away with an NTRK inhibitor. And this leads me, unfortunately, also to a challenge. So you can see in the paper we published 2021, we see the most survival benefits, because you can see here the blue line is the survival or the progression-free survival for patients treated with a targeted therapy with a very high priority versus all of them. And here's just treated with a targeted therapy versus a non-targeted therapy. And we only see a difference when we treat with a treatment against a very high priority, which also limits, of course, the numbers of patients we at this point expect really a survival benefit. So for some of the entities, you can see the Ewing sarcomas, the medullus. Unfortunately, we just don't have very high targets at this point. So only 5 to 8% of our relapse population really we can or will really benefit at this point from our registry. So then another way we're trying to tackle this, and we are currently also developing new algorithms. So for example, now we stand as a standard, we are reporting the tumor mutational burden, as we all know that it might be a good indicator for a good immune checkpoint inhibition response. So this involves the mutational burden for SNV as well as indels. Similarly, we also now started to implement the MSI sensor, so we're reporting back if we see a high microsatellite instability, which is in about like 5% is our cutoff. And you can see some of them here, down here you can see the tumor mutational burden. So there are a couple of patients which have a high mutational burden, but not necessarily a high MSI score, and vice versa. And there are papers out who suggest that since the MSI score actually correlates a little better with the indels and not just with the SNVs, that might indicate some of them, or is an additional or even a better marker for immune checkpoint inhibition response. Down the same line, we are also now paying attention more to the immune microenvironment. So we're having 2 algorithms currently running. We're checking once for this little deletion here on chromosome 14, which is specific for the T cells. So by estimating how deep this deletion is, we're kind of estimating the amount of T cells in the tissue, and also using the RNA data to estimate the amount of T cells. So with this, we would report a high or a suggested high amount of T cell infiltration. And here I want to show you, for example, one patient, I think it's from Norway, this patient, a 2006 born patient with a renal cell carcinoma. And you can already see here, there's a relatively clear deletion on chromosome 14. This was then confirmed by staining that there is actually a high infiltration. The patient was enrolled in our NEVAN study, And it was a very fast and persistent clinical response for NIVA within the 6 months treatment. But I also have to show you, if you check the microsatellite instability as well as the tumor mutational burden, both were actually quite low. So I think we're not at the end understanding the biomarkers completely, and we have to be careful to just go for one or the other biomarker. Another thing which is very exciting, we are now also doing phosphoproteomics profiling. This we do together with our adult counterpart in Heidelberg. So we have, I think we probably know by more. Currently, we're only doing profiling for sarcomas. We have done 12 prospective cases, and we're checking over 8,000 proteins and over 20,000 phosphocytes. And here's one example where it's really nice confirmation. So you can see clearly on the copy number plot amplification CDK4. In this alveolar rhabdomyosarcoma, you can see an overexpression of CDK4, and you can see this really high expression of the protein. So especially for cases where we're not so sure about the relevance of this alteration, it's really nice add-on to check maybe for downstream targets if this actually has an effect. And last, which is really, it's actually not this new anymore, whenever we also get sent fresh material, we also run a drug profiling screen. And this is also all done within these 2 weeks, 2 to 3 weeks. And also this adds a very high value, especially for targets we find only on RNA. And then if it matches nicely with some drug response, it definitely encourages or discourages then to suggest the treatment. So there's some additional results. For 8% of the ZNS tumors, we can actually refine the diagnostic by methylation. This was a little bit old data, but I think the number unfortunately didn't change this much. We only, about 4% of our informed population actually ends up in a real clinical trial. This doesn't include compassionate use. And for about 8%, we find a germline alteration, and about half of those 8% knew it before. And all this leads to that we can actually identify more tumor-specific alteration and a better understanding of the tumor biology. And this is why I want to give you a quick example of how Inform can be used for resources to do research. So that's actually from my own little research. Here you can see close to 400 high-grade patients classified by methylation. So we have many subtypes. All these patients have whole genome, like the same whole exome RNA-seq, and it represents actually nicely almost all WHO subtypes. And here I want to show you, if we now look at the germline data, we're actually quite surprised because usually the literature reports around 10% of pediatric cases have an underlying constitutional pathogenic variant. For the high-grade gliomas, it's definitely a little bit more. It's about 13% in our cohort. It mainly is, as expected, Li-Fraumeni syndrome as well as MMRD syndrome. But if you look now closer about the subtypes, you can see that actually it's not random. So the IDH mutant, IDH subtype tumors have a much more enrichment of MMRD as well as the PEDARTK2, and vice versa. For the Li-Fraumeni, it seems like to be somewhere centered around the PEDMIC-N subtype. So I'm currently writing this manuscript, and I'm obviously trying to follow up a little bit to figure out how this happens or why it's so subtype specific. And another thing is, like, if you go across the entity, it's about 10%. But then if you check per family or even per subtype, you can see that for some of the subtypes, like I mentioned, the IDH or the PEDARTK2, it goes up to 70% of the patients. So whenever a clinician sees a PEDARTK2 patient or even an H3 wild type patient, they should definitely get genetic counseling because some of this, like the MMRD, could have a real change to the treatment plan. So to ask the question, do we need more trials or more precision? I think we need more precise trials. So we need much better biomarkers up front. That's part of why we're taking mainly relapsed patients because, as we said before, they are out of options, so the likelihood that they're actually trying targeted therapy is high, but still we need to be much better in profiling the patient and identifying the best fit. And this, I just want to show you briefly how the reports look like. So every Friday we meet. We usually have somebody from the clinical side. We have the treating physician, the national coordinators. We have genetic counseling in it. Then from Heidelberg is always 1 or 2 treating physicians there, because as we mentioned also before, quite often we don't know what to do with the results. So just to try to gather as much of experience, it's always helpful. So then we start the tumor board by I give a quick overview of the patient. We mention when was the patient born, what was the diagnosis, and then also what was the treatment so far, especially has there been some targeted treatment before. And then we add some comments like about the methylation and the tumor mutational burden. And then this is how a typical slide look like. So we are listing per slide a target. And then here, for example, you saw that we noticed a clear rearrangement in NF1, which also fits to the neuroblastome. But since we couldn't really figure out if it's really an actionable deletion of NF1 or what is exactly going on, it got a lot lower priority. So we are kind of adjusting our priority also a little bit on what we know or what we don't know. And then we present it like this. So we in Inform are not allowed to give any kind of treatment recommendation. We can just present what we found, and then usually discussion goes on amongst the treating physicians. And there's another example, for example, from a MET mutation. We always write a little paragraph about what MET does, and has this mutation found before? Does this mutation fall into a domain? And also in this case, there was a slight gain, and then it got a borderline priority. So to summarize, I think the opportunity of molecular driven drug treatment is really high for pediatric cases, especially as it's so simple quite often. This entire program is very feasible. The hereditary predisposition syndrome is very much underappreciated, and I think it has to be much more a standard of care. High and very high evidence targets are unfortunately still rare, which also means we need better drugs for the targets we're having. The microenvironment still is poorly understood, and I think it's a huge opportunity for new treatment approaches. And we need international collaborations on all levels in the pediatric field, as the subtypes are so small and we just don't have the numbers to find new targets. And we're actually starting currently with our partner programs from the Netherlands, from everywhere, to actually combine the data, similar to a C-Bioportal cloud, that also researchers have access to this huge data we're having available. And with this, I want to also just point out that in Inform, there are many, many people involved. This is about sequencing during Christmas, sequencing any kind of holidays. We never pause the tumor board. It's every Friday. And this is only possible with many, many people. And please feel free to contact us, Inform, myself. We learned so much over the past 10 years, and the fact that we're able to report the data within less than 3 weeks is just because we got so efficient in doing the same thing over and over, and we are so happy to share what we learned. And yeah, so please feel free to contact me. And that's it, and thank you for your attention.
Thank you, Mirjam. We will definitely contact you, I hope. And now we will start our question-answer session. Please be active, and all speakers are invited to take a place here.
Thank you. It's quite difficult to see. Maybe somebody could show. Is there any question in the audience? Not yet. Oh, there is.
So thank you for all the speakers. I actually have a question to the last speaker about this molecular tumor board. So do you have, how do you look for these, for example, clinically relevant findings? Do you have some automation in the system? And then the second question is that when do you get these different type of the findings from RNA-seq data, drug testing data, as well as exome sequencing data, do you somehow integrate the results? So do you give more tiers to those findings, which you have more of the evidence from different type of the omics?
So,
thank you.
Yeah, thank you. So we don't, in our prioritization, we don't integrate the proteomics and the drug screen yet. So we report it just because we don't know yet, really. So we can, yeah, we want to let it run for a couple of months until we have a better feeling. Does it really support? Does it match or not? And my gut feeling is it's not about very high targets, because for them it's pretty clear. They work, yeah, for the NTRK fusion, for the BRAF mutations or BR fusion, but for the RNA-based overexpression, because there they get super low scoring, and we have seen already in drug screens that they're still sometimes responding so well to the matching drug. So I think for this it's going to be a huge benefit to integrate it. And for your first question, you asked whether it's already a little pre-filtered. Yeah, so we do it manually. So it's just, we were trying everything. Obviously, we get also approached quite often if we want to try out some home pages or if we want to, but we ended up, like, every time we're using some automated system to get the, because it's not so difficult, right? We have a library, or we have about 350 genes we know they are somehow either directly or indirectly targetable, right? So it's easy to filter our list against those genes. It's not a problem. But then we still have to look at them. We still have to look, where does it fall? What is known about it? And every time we're using some automated system, going back and looking at it takes us almost longer than doing it ourselves. So it's a lot of work. We got so efficient because we have all the slides pre-prepared for every entity, for every target, and we just kind of do copy-paste, adding it a little bit. But we still find that doing it ourselves is better. But it's a lot of work, and we're still, in the background, we're still constantly comparing automated systems.
Actually, I also have a question for the last speaker. It was a fantastic talk. I really enjoyed it. You briefly mentioned drug response profiling in your presentation. My question is, have you thought about integrating functional assays systematically to test the drugs before giving it to patients?
So not beforehand, because we don't have this time. So the library is an FDA-approved library, right? So the drug would be all theoretically available to be used. What we're doing now as side project is obviously also doing in vivo, because we always try to establish cell lines with it, PDXs and cell lines with it. But what we can't do is to really test like everything which then ends up being given or not, just from the timely manner.
The reason why I'm asking is because it seems that several groups, they have good results with pediatric leukemias, and that's the reason why I was asking.
Absolutely, and I mean, this is mainly done in Switzerland for us, and what we do with every patient which is registered with us is really encouraged to document for the next at least 2 years. So we have the drug profiling results, and obviously then it's going to be a nice publications to look backwards. What did the patient might get, and what did the drug profiling suggest, and does it match or not? So we follow up on the patient's survival and treatment.
Thank you.
In this moment, I don't see any hands, or... Oh yeah, there is.
Thank you very much. Unfortunately, I heard the last speaker only, but I was coming from a previous session on human capital. And we talked about challenges that the education system faces currently in order for instance, for boards like that to work more faster and things change faster. When you look at your perspective, what is your advice to policymakers, both for ministries of health and ministries of education, how to boost your work? Thank you.
Just one quick note to it. So it took us, I think, about 5 years with constant knocking at the door at the health insurances that we finally, since 4 months, health insurance pays for it. And we kept knocking on the door and we kept saying this is important. Because the pediatric field is so small, I think they were more open to the idea to pay for it, right? And it actually is a huge burden on us for the documentation now. But just keep knocking at the door and be annoying. We use even things like Twitter, because now the absurd situation that some of the health insurance pay for it and some not. So there are parents who are like, okay, now we're in the wrong health insurance. And then we write the stuff on Twitter and things to just pressure the health insurance to join our board, yeah.
Yeah, I think one of the speakers this morning said that if you have a lot of resources, that may hold you back, and you have a lot of history. And I think the latter, at least in our case, is definitely true. If you start from scratch, I think you would do things differently than a lot of what we do now, because we have a lot of history and we're used to what we're doing, have been doing for the last couple of years. So I think for policymakers, it would be good to have an eye on the future, and not the next 2 years, but perhaps the next 10 years, and also make sure that we look on the opportunities. And with that I mean, so for example, in the Netherlands, we have very different lab specialties, right? We have microbiology, we have pathology, we have hematology. So if I do sequencing on a solid tumor, there's for me a totally different reimbursement if I do exactly the same test on a hematology case, which is weird. Now we move into whole genome sequencing, we get the germline mutations from the same data, but that declaration, the reimbursement goes to the genetics department. So, and sometimes they don't trust our results, they do it again. So that's a waste of money. So I would, if we're now looking at, for example, whole genome sequencing, there's a lot of opportunity, I think, with germline testing, HLA typing, pharmacogenetics, but then the system should work for us to be able to do that and not against us.
Thank you. Some more hands? Then maybe I have a question to my colleague Dace, because we listened to Inform, to experience from Princess Maxim, and I believe that in your mind you have already ideas how you can improve your things you are doing in our hospital.
Yeah, thank you. So we had already yesterday a very nice conversation with Bastiaan. So, well, for me it's like, give me a little bit more money and I will do everything. So it's also the same for the policy making, that sometimes you need to make big investments for small patients. But for those small patients, these big investments are the main thing. So I think for all of us, the main thing is the patient. Those children who need our help and to whom we can help and make everything better.
Maybe one point, what you have next step, what you need to do things faster. There are stakeholders in the audience.
We need nanopore, yeah.
Is there any other questions or? Oh, yeah.
Hi, my name is Päivi Estling. I come from the Karolinska Institute in Sweden. Thanks for a great session. I've been listening interestingly. I have a curious question as to you all collect lots and lots of data that you try to implement in the clinic. However, have you also linked additional researchers actually mining your data to do the new findings, to make the next break, rather than just implement approved drugs?
Yeah, so your question is what we do with the data, right? Of if we do something with the data. Yes, so I think that's one of the examples I mentioned. We could have started with a small gene panel and with fish assays when we started the hospital 5 years ago. The reason why we didn't do that, because our researchers are not really happy with 2 fishes. They want whole transcriptome sequencing, they want whole exome sequencing, actually they want whole genome sequencing, so that's why we're also switching now. I don't think we have to switch from a diagnostic point of view. I think we're pretty good there. But for research, that's preferable. So all the data we sequence, we do in a diagnostic setting in an accredited lab, but the data goes into our biobank, and the patients that consent for research, which is like 90%, 95% of our patients, the data can be handed out again to the researchers in the institutes. So there's like a catalog, they can search which tumor types have been sequenced, what data is available, and they can request it. So yes, and there are like 40 different research groups, so they can reuse the data, yes.
And to add on this for the Inform, where there's also some Dutch patients in it, you can request the data to do some research, but this goes through a panel and this decided on. Especially with the new EU law, it's not so easy actually to share the sequencing results, or the raw data at least, but we are very open to share it. And like I said, we actually got a grant to integrate the data from different sites and to make them more accessible, because it's a huge opportunity for research.
So in Riga, we actually do mostly the diagnostic setting, and we are not sharing data with research, but most probably this is one of the ways how we can develop further. As I said, we started just now, only it's not even 2 years, so I think this could be one of the reasons how to move on.
Maybe I can ask you both the question regarding data sharing, whether you need a bioethics approval for the data sharing that are already stored at your institution. I mean, this international data sharing, how it works in your countries.
So no, we don't need additional approval, because the patient consented for research, and only those data we can hand out. Usually we have a research collaboration in place to make sure that data is being used for pediatric oncology research. But other than that, I think it's fine. So it's not only, the data is not only available for internal use, but indeed also for external use, yes.
So at least in our setting, our biobank, they need to apply additional requests to the bioethics, and then they are able to release the data stored. I mean, this is the problem of our data sharing across Europe, because as I mentioned, there are differences in this GDPR interpretation in data sharing.
Yeah, so as long as it's within Europe, there's no problem. If it goes to the States or somewhere else, then there are usually other legal issues involved. But as long as it's in Europe, it's okay. Yeah.
Thank you. It actually fit very well with other sessions planned during this Precision Medicine Networking Forum, because data issue is in different groups are on table, and how to make it easier from one point of view, but from another view to keep them safe as a user for benefit. Yeah, thank you for raising this question. Okay.
No questions from audience?
Okay, if there's no questions, then we can wrap up, and thank you, all of you. It was, I know that it was an exciting session. I already knew it before, and let's go for a coffee break and continue to network and to share our ideas and knowledge. Thank you very much.